Slide. You can start.
Started. Video is going on.
Yes, yes.
Okay. Good morning, everyone. Today I will discuss about C-section. What is C-section? Uh, what are the causes? What are the indications why we are doing C-section? And what are the complications? How we proceed for the C-sections? What are the steps for C-section? This is Dr. Tejashree as a senior resident in OBGY department. So, as we will proceed, what is the definition of the C-section? An operative procedure to deliver a viable fetus or more after 28 weeks or 20 weeks according to the ACOG guidelines through an abdominal and uterine incision. So, it's an operative procedure that you all people know to deliver the fetus mostly after 28 weeks through an abdominal and uterine incision. So, how much incidence are there? Increased from 5% in 1970 to 25% in 1990 due to procedure as high forceps and difficult mid forceps are abandoned in favor of C-section. Increased caesarean delivery in breech presentation. Destructive operation are abandoned in favor of C-section. Decreased morbidity and mortality due to C-section encourages its use. Increased repeated C-section due to increased primary C-section. What are the indications? There will be a maternal indications and fetal indications. So what is maternal indication? We will proceed for first maternal indication. First indication is contracted pelvis and cephalopelvic disproportion. Second will be pelvic tumors, especially if impacted in the pelvis or cancer cervix. Third, antepartum hemorrhages. Hypertensive disorder with the pregnancy. Abnormal uterine action. Previous uterine scar as a hysterectomy. What is hysterectomy? Before 28 weeks, it will be called as hysterectomy or metroplasty. Previous successful repair of vesico-vaginal fistula. Indications again, previous caesarean section. If the cause of previous caesarean section is permanent, example contracted pelvis. Previous section was upper segment. Suspected weak scar as evidenced by history of puerperal infection after the previous section. Hysterosalpingography or hysteroscopy done after the previous section reveals a defect in the scar. Vaginal bleeding during current labor. Marked tenderness over the scar during current labor. Associated condition as antepartum hemorrhage or malpresentation. Then we will proceed through fetal indication. What will be the fetal indication? Malpresentation and malposition. Prolapsed pulsating cord or fetal distress before full cervical dilatation. Diabetes mellitus. Bad obstetric history as recurrent intrauterine fetal death in last week of pregnancy or repeated intranatal fetal death. Postmortem C-section done within 10 minutes of maternal death to save a live baby. What are the types of C-sections? According to the timing, there will be elective caesarean section. The operation is done at a pre-scheduled time before the onset of labor, usually at completed 39 weeks. Selective caesarean section. The operation is done after the onset of the labor. So there will be a difference between elective and the selective. Then, according to the site of uterine incision, upper segment caesarean section, the incision is done in upper uterine segment and it is always vertical. Lower segment caesarean section, it is a commoner type, most common in fact. The incision is done in the lower uterine segment and maybe it is transverse or vertical in the following condition. Presence of lateral varicosity, construction ring to cut through a deeply engaged head. Then according to the number of operations, primary caesarean section for the first time, repeated caesarean section with previous caesarean sections. What are the types? According to the opening of the peritoneal cavity, transperitoneal, the ordinary operation where peritoneal cavity is opened before incising the uterus. extraperitoneal. The peritoneal cavity is not opened and the lower uterine segment is reached either laterally or inferiorly by reflecting the peritoneum of vesicouterine pouch. It is indicated in case of infected uterine content as chorioamniotis. Then we will proceed of time of Caesarean section, elective. When the Caesarean section is done as a planned procedure to ensure optimal preoperative preparation and surgical condition. Emergency, when the Caesarean section is done because of sudden deterioration in maternal fetal condition or during labor due to non-progress or failed induction or failed trial. Advantage of elective C-section. Preoperative good preparation as regards sterilization and antiseptic measures, fasting and bowel preparation. The risk of puerperal sepsis is minimized. The operation is scheduled and working is in the ease. What are the disadvantages? The risk of immaturity of the fetus or its lung is present. Higher incidence of respiratory distress syndrome. The lower segment may not be well formed. Postpartum hemorrhage is more liable to occur. Imperfect drainage of lochia as the cervix is closed, so it should be dilated by index finger or introduced abdominally through uterine incision. So briefly, most commonly employed type. Most LSCS, lower segment Caesarean section. It is most commonly we are doing. Involves lower segment transverse incision rather than vertical incision. What is lower segment Caesarean section? Preoperative actions. Valid informed consent. It is very important. Consent should always taken before pre-operation for every patient, for every single operation. After that, injection ranitidine 50 mg IV half to 1 hour before the procedure. Injection metoclopramide 10 mg IV half to 1 hour before the procedure. Ranitidine is a antacid and metoclopramide is antihistaminic. Stomach should be empty, bladder should be catheterized, fetal presentation, position, FHS should be checked. As an anesthesia, you can prefer spinal, epidural, general anesthesia according to the patient. Position, dorsal position, 15-degree lateral tilt to prevent supine hypotension or venocaval compression may be given. Then abdominal cleaning and draping. Then abdominal incision. What will be the preferred incision? Most common is transverse, what we call as a phalansteal. Post-operative, in these, what are the advantage of transverse incision? Post-operative pain will be less chances of wound dehiscence, incisional hernia. Cosmetically, it is better. That's why we always prefer transverse incision, that is called as phalansteal incision. Second will be vertical infraumbilical midline. What are the advantages? Rapid entry into abdomen, capable of extension, blood loss will be minimal. But we still prefer lower segment transverse incision only. And then what are the advantages in again lower segment? Apposition will be better, less bleeding due to less vascularity, less active uterine segment, healing better. Stage during subsequent pregnancy is along the line of incision. Chances of rupture during subsequent pregnancy or labor are less in the lower segment transverse. Upper segment vertical incision, there will be access to lower uterine segment is restricted because of adhesion. These are the indications, guys. Lower segment approach is not possible due to anterior placenta previa, large fibroids in the lower uterine segment. Transverse lie, or there will be pregnancy with carcinoma of cervix, post-mortem Caesarean section. Here we prefer classical Caesarean section, that is upper segment. Then what are the steps of lower segment Caesarean section? As before I told about preoperative procedures, what are the steps we are doing in preoperative measures. Then after the incision, what we will do? Doyne's retractor is introduced in lower part of the abdominal incision to expose the lower uterine segment. Recognition of lower uterine segment is by the presence of loose peritoneum over it. The loose peritoneum is incised transversely and bladder is pushed down. The lower uterine segment incision should be made after centralizing the uterus to avoid injury to the uterine vessel along the lateral wall of the uterus. Then lower segment incision is made in the middle, depending till the membranes are reached, and then extended laterally by stretching to create 10 cm opening. The presenting part is hooked by the operator and delivered while the assistant applies fundal pressure. The placenta and membranes are delivered and inside of the uterus is inspected for any abnormalities or completeness of removal of contents. The green Armitage hemostatic clamps are applied to the angle of the uterus and margin of the uterine incision to achieve control of bleeding. The uterine incision is closed in a single layer with a chromic catgut number 1 or number 2 using an interlocking running suture to achieve hemostasis. It is not necessary to close the visceral and parietal peritoneum layers. Peritoneal toilet is done and abdomen is closed in layer. What are the upper segment Caesarean section indication? Dense adhesion, extensive varicosity, myoma in the lower uterine segment, making its exposure or incision through its difficult. Impacted shoulder presentation. Anterior placenta previa. Defective scar in the upper segment. Cancer of cervix. Rapid delivery is indicated if a concomitant tubal sterilization will be done. Postmortem hysterectomy. Upper segment Caesarean section procedure. Abdominal incision will be vertical. In the lower segment, it was a transverse. Okay. Then uterine incision. 10 cm vertical incision is made in the midline of upper uterine segment without incising the peritoneal cord separately, as it is adherent in the upper segment. Okay. Extraction of the fetus. As a breach in the cephalic presentation, the last layer of uterine incision closure includes the superficial part of the myometrium with the peritoneal covering. The remainder of procedure is as lower segment. Everything other than that while closing is the same thing as we do in the lower segment Caesarean section. Only the incision will be vertical. Do not separately we have to incise peritoneum as it is adherent to the upper segment. That is the important thing. What will we do in the post-operative care? Palpate the uterine fundus as a location and consistency. Encourage early breastfeeding. Oral fluids after 24 hours. Discharge from hospital after 96 hours, that means 3 to 4 days. Stitch removal on 7th post-operative day, because healing will be there after 5 to 7 days. To avoid extraction for 4 to 6 weeks, contraceptive advice. So what are the advantage of lower segment or upper segment? Less blood loss will be there due to less vascularity, easier to repair. The resultant uterine scar is stronger. Less subsequent addition to the bowel and omentum. Less liability to acute gastric dilatation and paralytic ileus. Less liability to peritonitis due to better peritonization and healing. Type of C-section. So in classical, here I am showing this is the vertical incision where we will give the vertical incision. We will not separate peritoneum separately as it is adherent to the upper segment. The cephalic presentation we will deliver as a breech presentation, and the lower diagram is showing as lower segment Caesarean section. Here we are giving transverse C-section, and most of the hospital everywhere nowadays we are preferring the lower segment Caesarean section because the risk and the consequences will be a less, advantage will be more for the patient comfort and the bleeding purpose also. As previously I told you what will be the advantage and disadvantage in between lower segment and classical. Here just a flow diagram is there. as like flowchart is there to compare lower segment and classical. We will go through it. Apposition will be better in lower segment. Classical it will be difficult. Healing will be better in the lower segment. Classical it will be imperfect due to contraction and retraction of upper segment. Placental implantation may be over the scar in lower segment. In classical it was much more likely. Rupture will be 5 to 2%. In classical, it will be more like 8%. Timing of rupture in labor. In classical scar, in pregnancy also, it can be ruptured before labor starts. Infection, there will be least chances in lower segment. In classical, there will be more chances. What is a mode of delivery in subsequent pregnancy? The rule that Caesarean always Caesarean has been replaced since a long time by Caesarean always hospital delivery. If the cause of previous section is not permanent as contracted pelvis, vaginal delivery can be tried. So what is Caesarean hysterectomy? Hysterectomy is carried out after Caesarean section in the same setting for one of the following reasons: uncontrollable hemorrhages, unrepairable ruptured uterus, operable cancer cervix, cochlear uterus, placenta accreta cannot be separated, severe uterine infection particularly that caused by Clostridium vaginae, multiple uterine myomas in a woman not desiring future pregnancy, although it is preferred to do it 3 months later. What are the complications of C-sections? Operative complication. Primary maternal mortality is 4 times that of vaginal delivery, which may be due to shock, anesthetic complication, particularly Mendelssohn syndrome. Hemorrhage usually due to extension of uterine incision to the uterine vessel, atony of uterus or DIC. Injuries to the bladder or ureter, fetal injuries. Post-operative early thrombosis and pulmonary embolism, acute dilatation of the stomach and paralytic ileus, wound infection, puerperal sepsis and burst abdomen. There will be a chest infection. This was the early post-operative complication. What are the late post-operative? Rupture of the uterine scar will happen or there will be incisional hernia. Thank you.